Hello, welcome to a new year and another edition of ABC Psychiatry, where today Dr. Ani Ruda and me, Josh Elo, we get to review a head-to-head trial in treatment-resistant depression. Before we jump in, Ani, how are you?
Hi Josh, doing really well. How are you? Happy New Year.
Good.
This is our
Happy
first
holidays, happy New Year.
Happy
Yep.
holidays, Happy New Year. It's our first recording for the year 2024.
Yeah, took a little hiatus, but we're back. We're back. And with a good reason, because this is exciting. I don't know, Ani, I'm sure you get this a lot because we both do a little bit of teaching. And I don't know how often you get like well, should we do this one or should we do that one? We're talking with residents about like next steps for treatment. And it's like, well, shoot, if we had a head to head, that would be really be helpful. But there's just not enough of them in our field. And so to see something like this, a head to head of esketamine versus quetiapine and treatment resistant depression, it got me really excited. So I'm really excited for us to talk about this a little bit.
That's very true. I mean, for a lot of medical students and early trainees, and I felt that similarly, it sometimes felt like you were throwing darts at a dartboard and trying to figure out what is the best treatment option for your specific patient. So yeah, this is a very exciting trial and looking forward to this discussion.
So I briefly introduced us, but I do want to take a second to just acknowledge, Ani, you recently got a William Webb Fellowship Award. That's amazing. Congratulations.
Well, thank you. Very honored to get that fellowship award from the Academy of Consultation Leads in Psychiatry. And congratulations to you too, Josh. You recently were a recipient of the IPS, that's the Illinois Psychiatric Society Advocacy Award. Hearty
Uh,
congratulations.
Thank you. I didn't mean to just bring up yours so I could bring up mine, but thank you. That's very sweet. I'm very honored. Thank you. We're talking about a head-to-head trial with two treatment options, and I want to be clear because this study that we're going to jump into, it was funded by Janssen, who owns esketamine. So I want to be very clear. Like Ani and I, neither of us have any conflicts of interest. We don't receive any money from any of the pharmaceutical companies, and we're going to be talking about FDA-approved indications as well as off-label discussions. So just wanted to pause for a quick second to make sure that we make that very clear. All right. So, Ani, I think you had some questions about treatment-resistant depression.
Yeah, I mean, so we hear this a lot, right? Treatment resistance or treatment resistant depression, difficult to treat depression, non-responders, a lot of terminologies that go into discussing difficult to treat depression. And it's been difficult, also quite difficult to find a consensus about what is a specific definition for treatment-resistant depression. What are your thoughts about it, Josh?
Yeah, I think it's an incredibly important point. I think there's two main things that I think about with this. I think, um, as we've discussed before, depression is something that we've put into language in DSM, but it's imprecise, right? Like, there's lots of ways that you can get to depression. You can get there from what we call major depressive disorder. You can get there from bipolar disorder. You can get there from, Ani, in your world, you see this a lot from inflammatory processes or specific maybe iatrogenic like drugs that we use and for other medical causes can cause symptoms similar to depression. And so being trying to be precise with our language, I think, is really important so that we can try to unify what might ultimately be the underlying cause of whatever type of depression we're talking about. And um, so looking at that in like major depressive disorder or bipolar depression, I think we help clarify specifically what that might be with specific symptoms or characteristics that we can see. And one might be um, treatment response. Do our typical agents that work with serotonin, norepinephrine, dopamine, do they work? And if they don't, well, then maybe we should be thinking about something different or a different approach. And I think that's ultimately where we're getting to this idea of treatment resistant depression. It's kind of a controversial term. At conferences you'll hear folks who patients who get labeled with this as it feels kind of pejorative. It kind of feels like, well, like it puts almost the onus on them. But ultimately, what this really means is like our first line agents aren't good enough. They're not maybe doing the underlying work that we'd want them to do. And so if that's the case, then where do we go from here? So I think that's one thing to keep in mind as we're talking about this entity. And then the second
Okay.
one
And
is,
just to clarify,
yeah,
there is no specific DSM-5 definition or diagnostic criteria for treatment-resistant depression. Is that correct?
yeah. So we have some data about other subtypes in terms of like maybe melancholic features or anxious distress or some of these things that we can use to try to better describe the patient that we have in front of us. Um, but yeah, in terms of this idea of treatment-resistant depression, this isn't in DSM. This is a kind of newer idea that honestly is being led more so by, I think, newer drugs coming out and trying to find some niche maybe for an approval. But yeah, it's not currently in our main diagnostic structure of the DSM. And I think the other point about TRD that's particularly interesting is how then it gets diagnosed. And so I want to, or gets identified. This paper came out really recently, just in 2021, in Molecular Psychiatry. And if you look at the names of the authors here, it's kind of a who's who of thought leaders in psychiatry. The point of this paper was treatment-resistant depression is, we think, something, but we need to clarify exactly what it is we're talking about here. And so based on this paper, which is really important, they tried to put some specifics to these terms. And the specifics I highlighted over here. TRD, then they said, is less than a 25% response to a minimum of 2 of our antidepressants, typically SSRIs, SNRIs, maybe bupropion, something like that. So you're looking at you come in with depression. Maybe I do like a PHQ-9 or a MADRS or whatever it is that we're working on, and then I give you this drug. And after an adequate trial, do we get a significant improvement? And if you don't, with 25% is what they agreed on. That's TRD. It does talk about partial response depression as sort of a different flavor, maybe a slightly less severe, perhaps, where you can have up to a 50% response with one antidepressant, and that's partial response depression, which maybe means something for augmentation or changing your treatment approach. Like, there's some interesting ideas of what that could mean. And then this was specifically for codifying this sort of language for clinical trials, which is important because we're about to talk about this clinical trial, to say, like, if you're going to come into this trial, this is how we say that you are treatment resistant. Now, Ani, I think the part that makes this interesting for you and me, the clinicians in the room, and maybe other clinicians who are watching this, is um, it can be easy to find somebody who hasn't responded to a couple of our treatment options, right? And
Yeah,
so uh, treatment resistant depression, I think before this language was put together, I was thinking, like, have you done, an MAOI? Like, how far down the algorithm are we to call this treatment resistant depression? This suggests something a little bit earlier, maybe in your treatment approach.
agreed. I mean, this is when you actually really think about treatment resistance, right? At least in my mind, that's used to be the old thought that it's really resistant to several different classes of antidepressants. And honestly speaking, if it's minimum of 2 antidepressants, it could just be something like sertraline followed by escitalopram. I
Yeah,
think the key here, however, is the 25% response, right? And I think a lot of times as clinical psychiatrists, we're not always using measurement tools. We're using more of an interview method of determining what percentage of response a patient is perceiving. So I think that may be helpful. I'm just considering, even in my own practice, does that help determine or have a better sort of understanding and gauge of which are the patients who are truly treatment resistant?
yeah, absolutely. Um, yeah. So, treatment resistant depression was kind of codified in that paper, but we know a little bit about what we could call treatment resistant depression based on some of the evidence we have out there, right? Like STAR-D, 2/3 of folks didn't remit after their first antidepressant treatment, and then 50% remitted after 2. So that's not necessarily saying those first 2 trials had less than a 25%, but it does suggest that this is a pretty big burden. This is a lot of folks ultimately kind of fall into a TRD population, which, as a really brief aside, makes me wonder, okay, is that a problem with our treatments, or is that really like a treatment resistance? Maybe just our treatments are completely off the mark as a first line, but I digress. And then in the paper that we're about to talk about, the clinical trial, they suggest that TRD affects about 10 to 30 people of patients who have major depressive disorder, and it's associated with a lot of bad outcomes: more hospitalizations, comorbidity, higher mortality, and higher suicide rates, economic burden. So really demonstrating an urgent need to be able to have some targeted treatments, and thus a head-to-head of, then if we have somebody who's failed a couple things, we really need to know kind of what is next to do.
Yeah, from the first two slides, I think the biggest takeaway for me is the fact that it is actually much more prevalent than we think it is, TRD. It's not only just the two antidepressant requirement, right? Fails two antidepressants, which is a fairly low threshold, like we discussed. And now the prevalence that they're coding here is up to 30%. It's like a third of our patients may have what meets criteria for treatment-resistant depression. And I think it's important to recognize, because if we are not treating them as such, as treatment-resistant depression, and therefore utilizing the tools that may be beneficial for this population, we may be spending more time, more efforts, more energy in treating them suboptimally as just a
Mm-hmm.
non-treatment resistant depression.
Yeah, really great point. There's a real lack of guidance for us then to do. Maybe because this is a newer entity, and the field is changing and trying to embrace this. But a lot of guidelines, they don't really talk about treatment resistance. They don't really help us know what to do next. APA's guidelines were for MDD were last in 2010. CanMat doesn't really give us any specifics about TRD. The AHRQ, which I didn't even know about their guidelines, frankly, suggests that, well, not really sure if like switching is terribly useful. I don't know, maybe augmenting, but it really kind of left with, we don't really know what to do, frankly. And part of this might be because esketamine is the first FDA approved medicine specifically for TRD. And a lot of these guidelines came out before esketamine was approved. So this is a dynamic thing in our field that we need to, as clinicians, we need to be paying attention to. So, Ani, New England Journal of Medicine. Wow, I love when a psych paper gets there, right?
Yeah, absolutely. One of the more interesting papers in psychiatry. Is this just a general NEJM, or is this the NEJM psychiatry? It's just the New England Journal of Medicine. Okay.
This is the one.
This
This
is
is
the
the
one. Okay.
grail.
This is the one. All right. That's awesome.
This is the one that you routinely publish in, right?
Well, yes. No, I do not.
uh, So, Ani, I wanted to walk through a little bit of these compounds because I think they're interesting. So, as I was just alluding to, esketamine was FDA approved for TRD in 2019, first one to get that indication, specifically treatment-resistant depression. This is what I was alluding to about maybe pharma, these new compounds are really pushing this new entity faster than our diagnostic criteria like DSM is. For those who don't know, esketamine is an intranasal spray. It's a treatment that is recommended to be taken twice a week for the first 4 weeks, and then go down to once a week later after those first 4 weeks. It's an NMDA receptor antagonist. The idea is that by blocking the NMDA receptor, that's primarily on these, they're called the GABAergic interneurons, and that then leads to a glutamate burst, which is different than what a lot of our other treatments do in depression. And then some side effects you can get is dissociation, sedation, nausea, hypertension. There's a potential for abuse. There's a specific REMS protocol for being able to administer this drug. Quetiapine is one of these atypical antidepressants, so a second gen. It's FDA approved for in 2009 as an augmentation for MDD, but notice that it was approved as an augmentation for MDD. It's not approved for TRD. And I think that's really important because if you look at the studies that led to quetiapine getting approved, it really did look more like that partial responder that we were talking about with that Delphi paper. It's that population, not really the folks who had 0 or less than 25% response to agents, which the esketamine pivotal trials did define. So a little bit of a different animal, so to speak.
It's very
You know
interesting.
this, yeah,
It's very interesting that they picked quetiapine as the head-to-head. But again, I think this is interesting because they're doing a treatment resistance depression trial, and they are doing a head-to-head trial, which doesn't often happen in research, in pharma research, right? This is actually, they are going beyond what they realistically require, and they're actually trying to do a head-to-head with a active pharmacological agent. So I think that's a plus for this trial. They could have easily gone for a placebo, which they didn't. They've used quetiapine, but it still makes me wonder why quetiapine. I would love to hear your thoughts. My thought initially was it is a good, because like esketamine, we know it works like really early, right? It works really early. You can feel the benefits. With quetiapine, not sure about the antidepressant effect, but at least some of the symptomatic management, right? It's
yeah,
rapidly anxiolytic. It can rapidly improve your sleep. And even with those two, you can get significant improvements in your depressive scores if you're measuring via a psychometric tool like the MADRS that they did in this study. What do you think, Josh?
yeah. No, I appreciate you bringing that up. I think it is. I think it's a little bit of uh, some good and some bad. You're right. This is a head-to-head, which is really exciting. It also isn't a non-inferiority study. It wasn't. It didn't. It was really like, no, we think it's better. We're going to do this study. We're going to prove that it actually is better than another option out here. And as a clinician, Ani, like you know this, we when we see folks who have depression, who have some level of response or no response, the question is, do I switch to a different antidepressant? Do I augment with something, maybe an atypical, maybe bupropion, maybe, I mean, there's a whole bunch of different strategies, right? Or, and then I guess that's ketamine could be in there. Or do I go back and maybe think about my diagnostic criteria and do something different? Like you have some options, but in the mind, it's like, okay, who do I augment for with an atypical? Who do I switch for because maybe these clinical features or these side effects or whatever? And so it's an important question. um, I think, especially if you look at um, the agents out there now, there's a lot of uh, movement in the field toward augmenting with atypicals.
Mhm.
And so I think the question here that was in Jansen's mind was, well, if that's really what the thought is, and that's what clinicians are doing, maybe we should put a head to head of us against an atypical to see really what is the next move. And yeah, specifically to quetiapine, like FDA approved for augmentation in MDD, quetiapine, uh, Abilify or aripiprazole, Rexulti, and cariprazine. That's all of them, right? I don't think there's another one. So of all of those, you've got partial agonists, and then you've got the Seroquel, um, or the quetiapine. It's an interesting choice to do that because the quetiapine, relative to those other ones that they could have potentially gone against, more sedation, more weight gain, more orthostatic hypotension, more constipation, arguably relative to the other ones. And you know, this isn't head to head, but this is kind of what we know from clinical experience and what we've seen from the trials. And so it does kind of say, well, if we're going to say against an atypical, which one should we go against? I don't know. It's an interesting strategy, and I think it was maybe uh, intentional to choose quetiapine because of some of the side effect burden.
Yeah, but I also feel like you said, some goodness and badness, right? Like it sounds like, it's not a partial agonist, some of the side effect profile might be higher. But like the immediate benefit from quetiapine would perhaps be a little bit faster, right? Like the sleep will improve pretty fast. It's very sedating. Anxiolytic benefit. Interestingly enough, quetiapine actually has a positive randomized control trial, a couple of positive randomized control trials for generalized anxiety disorder, though it hasn't
Yeah,
achieved
yeah.
approval for anxiety. So it's a very interesting choice, but I give them kudos that they're doing a head-to-head trial with a active comparator.
Yeah, absolutely. And don't get me wrong, quetiapine is no slouch in depression for augmentation.
No.
Although that study wasn't TRD, it did show relative to people who didn't get augmentation with quetiapine. And this was a blinded trial that led to the FDA approval. That the secondary analysis showed that quetiapine did separate from placebo on all the MADRSs except for the suicidal ideation, and so it does seem to actually be a legitimate treatment. You know, it's not just some indication that we got. Like it does look good for and but what your point is about who do I do an augmentation with quetiapine? Maybe my anxious person who isn't sleeping and can't eat. Oh, that sounds like a quetiapine person. Is that somebody I think about for Spravato? Maybe, maybe not. All right. So the methods. So like we were alluding to, this is a head-to-head. This is an open label. So this is important, right? Like this wasn't completely blinded. This is the struggle, frankly, with um, esketamine trials.
Yeah.
It's very easy to get functionally unblinded because you see somebody who's having a dissociation or having some of the acute nausea during the treatment. And so the way this was set up, which I think is reasonable, at the local site, they were open. They were not blinded to be able to know what active treatment that patient was on.
Mhm.
But then the raters who did the efficacy outcomes, they were central raters. So they were not local. They weren't aware of what the treatment was. They weren't, anywhere in the hallway when somebody's giving the treatment. They're completely separate and they're blinded. So they're the ones actually making the determination about the scores on the depression. And so that's the way that they approach this functional blinding that can happen, because it's going to be a pretty different experience if you come in to treatment and you get Spravato intranasal versus you get quetiapine oral. And so that might be a little bit tricky. So it's a single blind, like that central rater didn't know, but pretty much everyone else did. But they were randomized. And then the open label flexible dose, depending on tolerability and response with the quetiapine, it was anywhere from like 150 to 300. Let's see, 18 to 74-year-olds failed 2 to 6 antidepressants in the current episode. So that bar that we were talking about TRD, that you had to fail, which is less than 25% response to 2 or 6. There was a bit of a range about how many they actually failed in this episode. Then the IDS was a severity of the depression score. And so then, oh yeah, there was 2 phases to this. There was the initial phase at 8 weeks, and then there was also a maintenance phase for 24 weeks to kind of see the durability and some other interesting outcomes. And then 676 folks. It's a pretty decent size too.
So initial, like, just to clarify, so the first 8 weeks trial, the first outcome, the primary outcome was what, the attainment of remission. Is that correct?
Yeah, exactly right. Yeah,
Okay. And the
yeah.
maintenance was
So yeah,
looking for relapse, right? Like they tried to look at
yeah,
patients with relapse.
yeah, like durability of the response.
Durability. Okay.
So speaking of, so we saw remission in the initial phase was significantly more with esketamine as compared to quetiapine. So this is the top part of this graph here, remission at 8 weeks. And you can see that 27.1% of those who went into the esketamine group achieved remission at 8 weeks, as opposed to the quetiapine, 17.6% of the people in that arm ultimately went into remission after 8 weeks. That led to an odds ratio of 1.74. And then that was statistically significant, that separation.
Mhm.
And so then if we go to your point, Ani, about, okay, if you do get this response or this remission, then do you keep the remission? That's the bottom part here, which is a um, important clinical question too, right? Like if you have an initial response, like does this endure? Do you stay on it? Which in treatment-resistant depression with that economic burden, we want people to get well, but stay well, of course, right? So then in this bottom part, you can see here that the folks who then had the remission, we're talking about the 27% after week 8, then do they continue to have that response? Do they not have a relapse? Another way to put that. 21.7% in the esketamine group maintained that they did not have a relapse, as opposed to 14.1 in the quetiapine group that ultimately did not have a relapse, that stayed well. That one was not statistically significant, if I remember correctly.
Yeah, so I find it a little bit interesting. So I was like going through the methods section, and for remission, they defined it. The primary endpoint was remission, which is defined as a score of 10 or less on the MADRS, which is the Montgomery-Åsberg scale for depression. And then in the uh, secondary outcome, which was the relapse, which was at week 32 that they looked for, like how many people relapsed in each of those groups. They changed it a little bit. They defined the MADRS score as having worsened to 22 or higher at two consecutive assessments within 5 to 15 days of each other. So I am a little bit kind of confused about that. Like it goes from 12, or rather 10 or less for remission, to defining relapse as 22 or higher on the score. I give them credit that it's like two consecutive, but still, well, even with two consecutive, you're kind of sorting out a little bit of people. But I'm just a little bit curious. I'm not super familiar with the Madras, uh, but is 22, where does 22 sit? I think that would be interesting to kind of find out.
Yeah, it's like a mild to moderate.
Mhm.
I think I'm trying to think of some other studies that we've done where MADRS scores for people who come in typically are in the low 30s, upper 20s, and so 22 is certainly like symptoms are present. I think the way that they set that up is interesting. Like you can still obviously it's a different definition, right? Remission versus a relapse. And so you can have like a poor inter episode recovery. Like, is that really remission? But you're better, but not like this partial response, maybe is how we define that. And then if you do get the remission and you're able to stay, in it for some amount of time,
Mhm.
um, like the endurance of repeat assessments with the MADRS later to look for these relapses, it's a bit of a tricky animal to put into a clinical trial. Yeah, I, I think that a number somewhere is reasonable. To be quite honest, I don't know if 22 is if that's from kind of a standard of how we identify like a relapse specific to a current depressive episode. I'm frankly not sure if that's maybe from something
Yeah, it's
or if
probably
it
it
came about from
makes
yourself.
more sense from a sort of naturalistic diseases, naturalistic core
Yeah,
standpoint, right? Like you don't expect the symptoms to be really low, below 10 for a sustained period
yeah.
of time. So perhaps they're giving some leeway as far as the score is concerned over the 32 week total 32-week period. Yeah.
Yeah. And I mean, Ani, do you feel like that leads to greater like generalizability or applicability to your clinical practice to have that relapse bar be maybe a bit more accommodating of
Yeah,
some
I think
creeping up of
so.
the matrices?
Right, you're right. Because like, we as clinical psychiatrists, we won't necessarily quickly make changes just because somebody came in your follow-up visit of 6 weeks and they are having some symptoms, whereas over the last two or three appointments, they were doing fairly well, right? Like you still kind of are cautious about it. So this might be a little bit more naturalistic, and they might have accounted for it by changing some of the numbers for determining what relapse is versus remission.
Yeah. Yeah. An interesting point here is that more of the quetiapine folks dropped out during the study than the esketamine folks, and um, they kind of made an assumption that those people probably had like a poor response, so
Mhm.
they viewed that in terms of like the data as like a negative response, as opposed to assuming that they were cured and felt great, and then they no longer followed up. Okay, so then remission over time. So while the acute phase, or the initial phase, I should say, did that was the primary spot where we looked at remission. That was like a primary endpoint. But this question was, okay, well, if we keep going, does it get better with more treatments? I was just having this conversation actually with a colleague this morning about, well, after 4 weeks of Spravato, like that's when you make your decision. Are you going to keep going or are you not? And I think that's the way, I think on label, I think it makes sense about how we would do that. But this is interesting because if you look at the dark blue lines here, these are the esketamine group, and the shaded area over toward the left on the, I'm looking at the top panel here, is the initial phase, that primary endpoint, that 8 weeks. And then as we go into the maintenance phase, and then the y-axis is the percentage of patients who go into remission. You see, and then the light blue is going to be the quetiapine group. You see that both groups end up having more remission over time, not just the initial phase. If you have some folks who maybe have like partial response to esketamine, don't get into that remission, but they keep getting the treatments during the maintenance, they continue to get better and have a high and continue to have a chance of ultimately becoming somebody who goes into remission, to the point where at the end of 32 weeks, esketamine, half of the folks who got that treatment went into remission after 32 weeks, as opposed to quetiapine, 32.9% of those went into remission.
It's pretty impressive. 50% going into remission out of the trial population at 32 weeks. That's fairly impressive. And that also probably, like you were alluding to, tells us that 4 weeks may not be enough to determine if somebody's benefiting from esketamine.
I mean, to look at this population who has all of the poor outcomes, like we were mentioning, and then to find something that with patients you can get 50% response. I don't know. That's pretty eye-opening in my mind. It's hopeful, which in this disease we really need some hope sometimes with our treatments. Half could have this response if we're able to tolerate that and continue on with this specific treatment. Yeah,
And the other thing
I
just
agree.
want to mention is quetiapine did not fare badly. It fared sort of similar to what you would expect for a third of patients achieve remission with the usual treatments that we have. So quetiapine seems like achieved about 33% remission at 32 weeks, but obviously the esketamine was 50%. That's a lot.
Mm-hmm. And then dropout rates. So tolerability, like I was just alluding to, is really important. So here, similar color scheme where the dark blue is the esketamine and the light blue is the quetiapine, and we're looking similar time. And then, excuse me, forgive me, this is the changes in the MADRS score over time. And you can see the separation here at the primary endpoint, which is that 8 week mark, and then it endures. That essentially same separation stays throughout the maintenance phase. It doesn't look like there's really a different time order for these medications in terms of like one starts really kicking in at a different place than the other one. They're pretty consistent with that separation throughout.
But it's also like,
and then as
it's also interesting to note that both of them, but especially the esketamine, which is not unexpected, you had a fairly rapid response if you look at the curve, and then it tends to sort of peter down a little bit. But similar for the quetiapine, you did have a rapid response at the beginning, and then it sort of parallels out a little bit.
Yeah, that's a good point, because we do think about esketamine as being one of these rapid acting, and I think the data is suggestive of that. But the more and more I see of these clinical trials looking at the time course of treatment, both arms, the even in placebo-controlled trials, both arms tend to have a pretty rapid early response, and then it really separates with time. So this isn't totally dissimilar to what we see in even our placebo-controlled trials. It's a pretty rapid first initial drop. And then I want to bring up here, because it's where they reported that quetiapine did have quite a few more dropouts than the esketamine did. So at the beginning, you can see that 326 were in the quetiapine group, 325 were in the esketamine group, and then if we go all the way out to the 32 weeks, only 203 were left in the quetiapine versus 255. So there was dropout in both. However, there was definitely more in the quetiapine group. Perhaps we can guess. We'll get into the side effects in a second, but maybe there's a harder tolerability that I think we can kind of infer from quetiapine. Speaking of, so this gets interesting. Esketamine had more adverse events, which when you think about people getting this treatment and their experience of it, well, let me come back to that. And then quetiapine had more, oh shoot, it got cut off here, I'm sorry, more AEs, adverse events that ultimately led to stopping the trial. This is for those of you who are getting like reps coming to your office and talking about some of the trials. This is often something that gets reported. Is like, yes, they had adverse events, but it didn't lead to them discontinuing. And as almost like a surrogate for tolerability, like, yeah, they did have dry mouth, but they didn't stop because of it. Maybe a severity component there. Um, and then AEs, as well as lack of efficacy, might be a reason why people ended up dropping out, right? This was a pretty relatively long study. It's treatment resistant, so it can be difficult for folks to stay in it just because of how miserable they feel. And if they don't see something kind of working, being able to stick with it. So
Yeah.
those are things to think about as we're
And
looking at
also
this.
interestingly, like we often talk about adverse effects with patients, but I think the more important is people might experience adverse effects, but is it enough to stop the medication? It's always a risk benefit analysis, right? And it seems like from this data, yes, people did experience adverse effects with esketamine, but it was not severe enough that more people dropped out from the esketamine arm. And then a couple of things. One is it might not be as severe, the adverse effect, or it could be transient, right? For example, most of the adverse effects you would think about with esketamine would be during the course, just like immediately during the treatment, right? Like some dizziness, hypertension, dissociation. So those would be kind of transient side effects at the moment of treatment, and therefore more tolerable because it's kind of like time limited, versus some of the adverse effects that a medication like quetiapine might have, maybe a little bit more pervasive because you're sort of taking it daily.
Yeah, and I think it gets down to what to your point is the risk benefit analysis that we have with our patients all the time is like, okay, you're having this, but how bad is it? And that ultimately, I think it's down to severity, but I think it also gets down to the personalization of the work that we do. Like your sedation is good because the insomnia is so crummy, but your sedation is not good, and that's not going to make it work, though it's the same adverse event because of this drug and what we know about it. And then maybe a little bit of like the um, uh, pervasiveness of it, I think, is an interesting dynamic of it too. I think another part of it is um, uh, um, how expected it is, right? Like you're coming in for a Spravato treatment, you know that while you're there
Mhm.
for a couple hours, you
Yeah.
might have this. Where maybe some of the stuff that happens with quetiapine isn't as expected, or it's a bit of how you frame it too when you're talking about your medication options with your patient.
I mean, yeah, with the esketamine treatments, like you're observed, you're monitored, you're given a lot of education. Whereas quetiapine is another medication that you prescribe, right? So I'm sure people do the education, but it might not be as salient for patients in their minds versus compared to coming into a clinic to get a nasal spray and be monitored for the duration of the treatment.
So we touched on a number of these, and I'm curious if there's part of these that we've gone through that you have some additional thoughts on. I'm thinking about the just the nature of the study with being a head-to-head and it actually showing a separation, which in itself is pretty interesting. And what does that mean for our clinical work? The kind of keeping people on Spravato, even if they have maybe less than remission at an earlier time point, if that's interesting for our clinical work. And then, is it fair to put esketamine and atypicals in the same next step in your clinical algorithm, or if we should be thinking about that differently?
Yeah, those are all really interesting points, right? Like, first of all, you know, we've kind of repeat at the risk of repetition, they were quite gutsy about using a head-to-head trial versus a, placebo trial. Um, Now, what I find interesting is about the comparison of a atypical with esketamine. I
Yeah,
wasn't
yeah.
really thinking about it, like, when esketamine first came out. I don't know what your thoughts are, Josh. It has always been in my mind, comparison of esketamine with something like electroconvulsive therapy,
Hmm.
instead of comparing it with something like an atypical antipsychotic. A couple of reasons. One is like treatment resistance. You're thinking about non-responders. But on the flip side, I think my mind is open to being changed because as we are learning, treatment resistance is not what we generally think about. Treatment resistance is much more prevalent, much more pervasive. It's I think most of us, like all of us, not most of us, like all of us have seen treatment resistance. It's not something which is very uncommon. So that I'm trying to sort of contend between these two thoughts. One is, when you traditionally think about treatment resistance, you're thinking about electroconvulsive therapy, monoamine oxidase inhibitors, those kind of things, right?
Yeah. Yep.
And then adding onto it ketamine. And on the flip side is the fact that perhaps we're wrong about it. Perhaps treatment resistance is different.
Yeah, I think with this evidence, I think it does suggest that we should be reaching for that Spravato referral, honestly, a little bit sooner than I'm reaching for starting an atypical in this population who really has had no response to the first couple things that I've tried. Um, I, and you know, it's looking at the evidence. If we do look at the atypical augmentations, I talked about how it's really a partial response population was coming into those trials. And the primary endpoint in those studies really was response. It wasn't even remission. And
Remission.
that's how they got their approval, right? And so the goal is remission. The goal is to get people back into functionally being able to engage in their lives. Some people can get there with response, but remission really is what we want to be able to get there. And if that's the bar, I have a hard time going to the atypicals, and
Mhm.
unless there's a specific need to go there. Again, like maybe going after the side effects that might be particularly important in the individual with insomnia or anxiety, or maybe some agitation, or maybe mixed features, which is a different discussion. But that all gets to something that I feel like I harp on a lot is we need to have a better clarity of subtypes of depression to see who we're going after. This is a subtype, people who don't respond to our first two lines. And then it seems like Spravato maybe is that. But if we're going to be more specific with our treatments, we need to look at, hey, MDD with anxious distress, who do I put? Do I do that? Do I do Spravato there? Do I do an atypical there? Maybe because it is a little bit more on the sedating side. I think that's the next step here. And I think a study like this really paves the way for subsets of populations, and then doing these head-to-head trials to see in this person, who do I actually go for? And frankly, we don't have enough out there to give ourselves informed decisions.
I love the fact that you brought up the subtypes of depression and how, personalization of depressive symptoms is so important, right? Like we don't have good enough data, but I think that is something which is so important to see if we can find. Uh, I think classically there has been this association of, it's a nice segue, association of utilizing MAO inhibitors, monoamine oxidase inhibitors in patients with predominantly atypical symptoms of depression,
Yep.
right? And then, out of the pharmacological treatments before ketamine came out, I would say when you're thinking about treatment resistance, you're often thinking about MAOI inhibitors, MAOIs, or lithium. Those are the two sort of that you think about often, and it's still unclear where they fit into this treatment algorithm, or we have a lack of a treatment algorithm, like we talked about, right? We don't have a specific algorithm to help treat treatment resistance or certain atypical or other subtypes of depression. And it's so important to try to do more research, try to not just like look at the scores, right? I think scores is one thing, but actually break down the scores into certain subtypes of depression and then see if there is a specific signal for one pharmacological agent or one class of medications versus the others. I think as psychiatrists often do it intuitively, depending on
Yeah.
sort of like the side effects or certain effects that certain medications have. But it would be nice to have similar guidance and some evidence when we're doing this for people who have been depressed for a very long time and have been struggling a lot. So it might be, instead of sort of doing more trial and error, I think it might be beneficial to having certain guidances of that sort for treatment resistance folks as well.
Yeah, I think to give some context to that, Ani, I think that a lot of the subtypes of depression really came from that's how we did it before DSM-3, right? Like
Mm.
it was neurotic depression, endogenous depression, anxious depression, and that's when we were using things like MAOIs or TCAs, and so
Mhm.
we had more, hey, in this population, because this is what we do, this is how we figure it out. But then DSM, we kind of threw it all into MDD, and we lost that specificity, and I think we've been wanting it for a long time, but now our newer agents come out and they just don't have the data that we had with some of the older ones, and so it's it's tough to compare to see if those are similar populations, similar subtypes. So I completely agree. Like having more with some of our newer stuff would really help clinicians like you and me have a better idea of what to do next.
Yeah, absolutely.
Uh, well, this is really lovely. 2024 off to a bang. I'm so glad we found some time to do this and we're able to catch up on this really important paper. I'm excited for our next one. Ani, it's really lovely to see you.
Likewise, Josh, and we'll try to be a little bit more regular this time around. It's been we had a bit of a hiatus, but we'll try to make sure that we're a little bit more regular with some of these recordings.
All right. Good to see you, Ani.
Good to see you, Josh. Take care. Bye bye.
Bye.